We, Yana, Jessen, and Nikki are going to represent you our scientific article for obtaining the DO diploma in osteopathy and Bachelor of Science with honors in the osteopathic medicine at the International Academy of Osteopathy. The title of our study is The Influence of Stomach Complaints on the Presence of Chapman Reflex Points, Jarricot points, and the influence on the related muscles. First, we want to introduce the background of Jarricot points, Chapman reflex points, and muscle-organ relationships according to applied kinesiology, to subsequently discuss the objective of the study. Afterwards, we will explain the material and methods that are used to accomplish the objective, followed by the obtained results, which are demonstrated with graphs and tables. At last, we will discuss the results and end with a conclusion. Jarricot points are discovered by Dr. Jarricot and are cutaneous zones which correspond with certain organs situated at the thorax and the abdomen. In 1932, Dr. Jarricot determined relationships between the underlying organs and the superficial tissues, which could be identified through a dermatome relationship. He described that reflex zones of the dermis are defined by the ciliated reflex and by a symptom, the sympatology. It is a sympathetic autonomous of the organ which expresses itself by a sympatology of the dermis. Jarricot's work resulted in a cartography of reflex dermatologies of the dysfunction of organs. He described the reflex zones of the dermis present by a functional or organic disturbance of an underlying organ which expresses itself in an abnormal dermis. Each reflex of the dermis has a defined form which is delimited with precision and is always situated in a particular dermatome and constant zone, coinciding with the development zone. The reflex is always homolateral situated for uneven organs or in the middle. For even organs, the reflex is symmetrically left or right. It represents the somatization of the dermis of the nerve system of the corresponding organs. This method is capable to access all disorders of organs but must always be evoked. The technique to access the reflexes is named skin rolling. The skin is picked up and rolled between finger and thumb to palpate the tissue quality. This demonstrates two aspects: the objective phenomenon, and named reflex dermalgias. This is a sensation of the thickened tissue. On the other hand, there is a more subjective aspect, namely the increasing intensity of a pain until a point of maximum hyperesthesia. The area where maximum of hyperesthesia is situated is always located at the level of the complex sympathetic dermis area, responding at the zone of thickness of the ventral roots of the thoracic nerve of the determining dermatome. The projection of the stomach is situated on the ventral side of the body just above the umbilicus in the middle of dermatome T9. It has an oval shape in longitudinal direction.
Frank Chapman discovered and used Chapman reflex points in the early part of the 20th century. Chapman has charted specific points on the anterior and posterior surface of the body, which are related to dysfunction in a predictable organ. These reflexes are described by Charles Owens in the 1930s. Chapman reflex points represent a viscerosymmetric reflex. The types of visceral dysfunction which result in Chapman reflex points are spasm, distension, and inflammation of the organs. Chapman reflex point is manifested by ganglion contractions, which are usually located in the deep fascia and periosteum. These ganglion contractions are considered to be a neurolymphatic myofascial expression of systematic diseases. Palpation of a ganglion contraction feels like a nodule with size ranging from an almond to a pinhead. The nodules may feel like shorty, rubbery, hard, and or ropey. Palpation of a ganglion contraction is frequently sensitive for the patient. But tenderness is a subjective sensation, and therefore the lymphatic congestion and change in myofascial texture is rated a criterion for a Chapman reflex point. The anterior Chapman reflex point of the stomach is located at the left side of the body in the intercostal space between rib 5 and 6 and between rib 6 and 7. The posterior Chapman reflex point of the stomach is situated at the left side halfway between the spinose process of thoracic vertebral 5 and transverse process of thoracic vertebral 6. The other posterior Chapman reflex point is situated between the spinose process of thoracic vertebral 6 and transverse process of thoracic vertebral 7. It's urged to use initially the anterior Chapman reflex point for diagnosis, because they are more extensive than the posterior Chapman reflex points. This removes the confusion of which organ is the cause of the Chapman reflex point. Confirmation of the organ diagnosis once an anterior Chapman reflex point is determined is obtained through the presence of the corresponding posterior Chapman reflex point.
Applied kinesiology is developed by Goodhart in 1964. It is a diagnostic and therapeutic system which is based on manual muscle testing. Muscle tests are an evaluation of proprioception, regulation of the spinal and central nervous system, and their effects on the neuromuscular function, then slowly an evaluation of the contractile strength. A decrease of normal neuromuscular function within and between muscles is responsible for most of the disturbances. Goodhart notes that organ problems cause weakness of the specific muscles. These direct muscle-organ associations are still not scientifically validated. Important aspects of muscle testing are precise start position, resistance direction of the patient containing an isometric contraction and correct timing. During muscle testing, there are two different responses. The subject maintains the test position. This means a normal facilitation of the muscle named normoreactive or an over-facilitated muscle named hyperreactive. The other possible response is movement of the limb, which means a hyporeactive dysfunction of the muscle. Hyperreactive and hyporeactive muscles are both dysreactive. Distinguish between a hyperreactive and normoreactive muscle is obtained with an inhibition method such as drainage point stimulation. A normoreactive muscle can be functionally weakened with this method, which cannot be done with a hyperreactive muscle. There are several muscle-organ associations of the stomach. In this, we only investigated the pectoralis major clavicularis muscle and biceps brachii muscle. Jarricot points, Chapman reflex points, and applied kinesiology can all be used as a research method for visual pathology and dysfunction. The objective of the experiment is to investigate the reliability of Chapman reflex points, Jarricot points, and muscle-organ relationships according to applied kinesiology as a diagnostic aid in stomach complaints. Determining Chapman reflex points, Jarricot points, and muscle-organ relationships as valuable diagnostic aids will extend the scope of tests, which detects visual dysfunction and pathology. Therefore, more tests can be performed, and this can result in an increase of probability of indication. This is important for the formulation of a specific medical and manipulative treatment for the patient and improves the quality of life for our patients.
This study contains a control group and an experimental group. The experimental group consists of 16 subjects with stomach placed on a regular basis. Beside these subjects, we have a control group of 16 subjects without stomach complaints. All the subjects are between the age of 90 years old to 70 years old. Two investigators performed the results. One investigator determines if a dysreactive pectoralis major clavicularis muscle and the biceps brachii muscle is present. In addition, the presence of the Jarricot point of the stomach is examined. The other investigator detects the presence of Chapman reflex points of the stomach at the anterior and posterior surface of the body by palpation. The reliability of these research methods as a diagnostic aid in patients with stomach complaints is investigated. This is achieved by comparison of the prevalence of Chapman reflex points and Jarricot points and the difference in strength of the pectoralis major clavicularis muscle and the biceps brachii muscle between patients with and without stomach complaints. The Jarricot point is present in majority of the experimental group and in a quarter of the control group. A positive Chapman reflex point of an organ is only obtained when both anterior and posterior Chapman reflex points are present. Combining the result of the positive anterior Chapman reflex point between rib 5 and 6, rib 6 and 7, confirmed by the associated posterior Chapman reflex point, resulted in 3 times more presence of a positive Chapman reflex point in the experimental group compared to the control group. This slide shows the distribution of the pectoralis major clavicularis muscle in normoreactive and dysreactive. There is made a distinction between the right and left muscle. A normoreactive pectoralis major clavicularis muscle on both the right and left side occurs in a double prevalence in the control group compared to the experimental group. This slide shows the distribution of the biceps brachii muscle in normoreactive and dysreactive. There is made a distinction between the right and left muscle. A normal reactive bicep brachii muscle on the right and left side occurs in minority of the experiment group and a majority of the control group. This slide shows a table with the p-values of the three components of this study. Only the Jarricot point and the bicep brachii muscle have a p-value below 0.05. This illustrates that both of them have a statistically significant relationship with stomach complaints.
A possible reason for the low p-value of Chapman reflex points and pectoralis major pars clavicularis muscle may be the size of the sample. This study shows a greater presence of a positive stomach Chapman reflex point and a dysreactive pectoralis major pars clavicularis muscle in the experimental group. Therefore, an increase of the sample may have positive influence on the p-value. To acquire good results, it is essential to perform the test correctly. This is only possible when the examiners have knowledge of the study and experience in performing the test. In this study, both examiners have a lack of experience in executing the test. During the entire investigation, the same examiner needs to perform the same test to limit inter-examiner variability. Likewise, the study.
The data of the study indicates a statistically significant relationship between the presence of the stomach Jarricot point and stomach complaints. This study also shows a statistically significant relationship between a dysreactive bicep brachii muscle and stomach complaints. This last finding indicates a valuable use of testing the bicep brachii muscle for confirmation of a stomach dysfunction. On the contrary, the statistically significant relationship between a dysreactive pectoral major pars clavicularis muscle and stomach complaints has not been proven. Future investigation is necessary for the other stomach-related muscles according to applied kinesiology. Another outcome of the study is the relationship between the presence of a positive stomach Chapman reflex point and stomach complaints, which is below the standards of the p-value. Future clinical investigation and well-designed research for Chapman reflex points is required. These results illustrate that only Jarricot points can be used as an added variable in medicine and should not be used as a diagnostic aid on its own. It is solely a confirmation of an indication. The probability of an indication increases when more tests are performed. This is important for the formulation of a specific medical and manipulated treatment for the patient. This improves the quality of life for our patients.